And again, good morning, everyone. This is Kathy Fauble from INET, Illinois Network for Education and Training. For those of you who have not attended a webinar in the past, with our organization, we do a variety of continuing education programs for healthcare providers around the state of Illinois. We do this primarily by webinar and offer nurse contact hours for our programs. So if you're interested in learning about other programs that we're doing, please check our website out. It's illinoisnetwork.org. We've got some really good things coming up this summer, specifically around leadership and management for healthcare providers. So check it out. We'd be glad to have you participate in future programs with us. A couple of announcements for today's program. If you did not receive a copy of the handouts or had trouble accessing those, again, you can go to our website. It's illinoisnetwork.org and go to the educational resource page and download those materials. Included there is the evaluation for today's program. We would request that everyone return the evaluation to us. Those are just really helpful to us and to the sponsors of this program as we move forward with future educational offerings. It is also required if you are wanting nurse contact hours for this program. If you're wanting nurse contact hours, you will need to complete both sides of that evaluation and verify that you have attended the entire event. Please make sure that your name is spelled as neatly and correctly as possible so that we can get that right spelling on your certificate. Make sure also that your email address is legible, as we will be sending that to you as a PDF. So be looking for that within the next week. We will also, during this webinar, right at the very beginning, be doing a couple of chat questions, polling questions. So if you could have somebody at your site be in charge of answering those two polling questions at the beginning of the webinar, that would be great. We'd really appreciate that. Let's see, we are offering one contact hour for nurses for this program, and the disclosure statement is here on your screen. Criteria for successful completion include attendance at the entire event and that submission of that completed evaluation form. Again, you can email that to us or fax it to us. The email and fax number are on top of the evaluation. Partial credit will not be awarded. The planning committee members declared no conflict of interest. The presenters have agreed to present information fairly and without bias. INET is an approved provider of continuing education by the Ohio Nurses Association and an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. This program is being co-provided between INET and the Center for Jewish Genetics, and though all tasks involved in planning and implementing this activity are shared, INET, as the approved provider unit, has maintained responsibility for key program elements. I do want to say a special thank you to the Center for Jewish Genetics. They have been great to work with. We've just been really thrilled at this partnership and are so pleased to bring this program to so many people across the state of Illinois. At this time, I'm going to turn some announcements over to Emily Foster, who's with the Center for Jewish Genetics, and let her make those announcements, and then we'll get started with our webinar presentation. If you have any questions during the presentation, be sure and chat those in. You can send me a private chat message if you have specific questions about what's happening on your webinar site. If you have questions for the presenter, you can send those to all participants, and the presenters will be happy to answer those questions for you. Again, thanks everyone for being with us today. Emily, I'll turn it over to you.
Thank you, Kathy. Good morning, everyone. Welcome to our webinar in celebration of DNA Day, Illinois. My name is Emily Foster, and I'll be your host today. I'm a social work intern at the Center for Jewish Genetics and have the pleasure of working on this year's Illinois project that is focused on the importance of newborn screening and family health history. So we have a number of objectives that we'd like for participants to be aware of because this is for the nursing contact hours. We'd like for you to be able to, at the end of this webinar, recognize the importance and impact of newborn screening, describe the process of newborn screening to patients, identify disorders being screened for and new disorders being added to newborn screening in Illinois, to identify the connection between family health history and newborn screening, to recognize how disorders and health risks are inherited, to outline benefits to gathering family health history to patients and staff, and illustrate the importance of family health history and newborn screening. For the past 5 years, the Center for Jewish Genetics, in collaboration with the Illinois Department of Public Health, has provided outreach to public health departments and other entities for the DNA Day Illinois project. This year, we are pleased to be co-providing this webinar with INET, the Illinois Network for Education and Training. In order to have a better understanding of who our audience is today, we would like to conduct a quick poll to find out where our participants practice. If you work for a health employer, please indicate which item best describes the type of health center you work in. So we'll just take a moment here to see if you could let us know where you're employed. And you would just, if you see the polling questions, you would just click on the description that best fits where your employment is.
Okay, and Emily, we've got the results back from those. The majority, 48% are from local health departments, 19% from hospitals, and the remaining are from other or no answer.
Okay, thank you so much for the participants who answered that question. We had one more poll, and we were just wondering, we thought it would be beneficial to find out what type of work our participants are engaged in the healthcare-related field or otherwise. So please take a moment to select a position here. Okay, and while we wait for those polls to come in, I'll go ahead and just move on with introducing our presenters. For today's webinar, we are honored to have two presenters who will share their professional and personal knowledge of genetic disorders and family health history with us. Our first presenter will be Michelle Gillis. Michelle is a licensed genetic counselor working in the genetics department at the Ann and Robert H. Lurie Children's Hospital, Chicago. She also provides education and carrier screening services in the community for the Center for Jewish Genetics. Michelle's passion for genetic health has also benefited students of Northwestern University's Feinberg School of Medicine. And our second presenter will be Marie Bonish. Marie is a person living with Fabry disease, which is one of the disorders being added to newborn screening in Illinois. Marie has multiple family members who are also affected by Fabry disease. She has previously presented her experiences to healthcare providers with groups such as Genzyme and the Fabry Support and Information Group. And we are so grateful to have both of these presenters with us here today. And it looks like our polls did come through, and the majority of people, about 76%, included in this webinar today, are nurses. And we have about 2% are genetic counselors, 8% are involved in other health-related fields. And we do have a few people who didn't choose to give an answer, and we appreciate the diversity here today. Thank you. And I'll hand it over to Michelle now.
Thank you, Emily. As Emily said, my name is Michelle Gillis. I will be first presenting on newborn screening, and I'll be happy to answer any questions that you have. Feel free to type in your questions as we go. Newborn screening is a public health program that celebrates its 50th anniversary this year. Dr. Guthrie opened up the possibility for newborn screening when he developed a way to screen for a genetic disorder called phenylketonuria, or PKU, and he introduced a method for collecting and transporting blood samples. Since its inception, newborn screening has reduced morbidity and mortality related to genetic disorders. Nationally each year, over 100,000 newborns have abnormal results from newborn screening. In our state, according to the Illinois Department of Public Health, approximately 165,000 newborns are screened annually. About 400 of those newborns screened are diagnosed with a genetic disorder. Before we discuss the newborn screening process, I want to review some basic genetics. Our bodies are made up of millions of cells, and inside our cells we have our chromosomes, which are the packages of information that tell our bodies how to grow and function. Chromosomes are made up of DNA, and a stretch of DNA is called a gene. Genes are the instructions that make all the proteins in our body, like the body's blueprints. We have 2 copies of most of our genes, one from our mother and one from our father. Some changes in our genes just lead to different traits, like different eye color or hair color, whereas other changes or mutations alter the function of the protein and lead to disease. Newborn screening involves a blood test performed by heel stick at the hospital within 24 to 48 hours after a baby is born. It can also include a hearing test and pulse oximetry. Pulse ox is not currently mandated by the state to be included, so it is performed in hospitals in Illinois depending on the hospital protocol. The purpose of newborn screening is to determine if a baby has a serious medical condition that requires intervention. The condition screened for varies from state to state. A state screening panel is determined by a number of factors, including cost, number of cases seen in the state, and changes to national recommendations for screening. These recommendations are called the Recommended Uniform Screening Panel, or RUSP. These recommendations are not enforceable by law. The RUSP includes 31 core conditions and 26 secondary conditions, which are conditions that are identified as a result of testing for the core conditions. There are several criteria by which the core conditions were chosen. The condition must have a specific and sensitive test available to detect it. The health outcomes of the condition must be well understood. There should be an available and effective treatment. An identification of the condition could affect the future reproductive decisions of a family. When I gave birth to my first child, the nurse told me that they were taking her to have a PKU test. I questioned her and asked if they were testing for anything else, knowing what the answer should be. She incorrectly told me that it was just a test for PKU. Unfortunately, many nurses still refer to the newborn screen as the PKU test, but it includes much more. Illinois currently screens for 29 core conditions plus 10 secondary conditions. This includes PKU. The benefit of screening for PKU is that with dietary modifications started shortly after birth, intellectual disability can be avoided. At Lurie Children's, we recently saw a newborn who was found to have a condition called citrullinemia, and that was found via newborn screening. This causes ammonia and other substances to accumulate in the body and can cause significant neurologic damage. Because of newborn screening, this baby was admitted to the hospital immediately for treatment. To the parents, she appeared to be doing well, so she would not have been brought to medical attention at that point, but on admission, her ammonia level was extremely elevated. Newborn screening likely saved this baby's life. Illinois will be adding 7 lysosomal storage disorders, as well as a condition called severe combined immunodeficiency disorder, to its newborn screening panel. I will briefly discuss the 7 disorders that will be added to the panel. Fabry disease is a condition that leads to pain, GI issues, possible stroke, renal damage, and cardiomyopathy. The treatment involves enzyme replacement therapy to prevent complications of the condition, and medications to treat existing symptoms. Enzyme replacement therapy is a method, as the name suggests, of reintroducing a missing enzyme into the body, usually by IV infusion. You will hear more about this condition from our next speaker. There are several different types of this next condition called Gaucher disease. Type 1, which is the most common form, involves bone disease, anemia, enlarged liver and spleen, and lung disease. Type 2 has similar symptoms to type 1, but also includes neurologic disease, and the children generally die by the age of 2. Type 3 is similar to type 2, but with later onset and longer life expectancy. There's very effective treatment available for type 1 Gaucher disease in the form of enzyme replacement therapy or a similar method called substrate reduction therapy. And for type 3, bone marrow transplant is available. At Lurie Children's right now, we have about 28 patients on enzyme replacement therapy for Gaucher and a handful who are in a clinical trial for an oral medication. In the infantile form of Krabbe disease, the babies exhibit irritability, hypertonicity, progressive neurologic deterioration, and blindness, and they generally die before the age of 2. In the late onset forms, the children have weakness, vision loss, and intellectual regression. Treatment involves supportive care in those with the infantile onset form, and stem cell transplant can be effective in pre-symptomatic infants and older individuals. Mucopolysaccharidosis type 1, or MPS 1, is a condition that used to be divided into 3 different subtypes with different names based on severity. These are Hurler, Hurler-Scheie, and Scheie disease. There's no biochemical difference between the types, however, so that this terminology is not as commonly used now. The symptoms of the severe type of this condition include coarse facial features, enlarged liver and spleen, skeletal abnormalities, hearing loss, corneal clouding, and intellectual disability. The attenuated type has onset between ages 3 to 10 years, and the severity and rate of progression is variable. Treatment includes stem cell transplant and enzyme replacement therapy. Newborn screening for MPS 1 is critical because stem cell treatment is beneficial for the severe form, which used to be called Hurler disease, and it is the only known MPS disorder where stem cell transplant is effective in stopping the progression of the neurodegenerative disease. MPS 2, also called Hunter syndrome, is a condition where, due to the pattern of inheritance, it mainly affects males, but some females are affected as well. Symptoms include enlarged liver and spleen and skeletal abnormalities. In the severe type, you can also see progressive cognitive deterioration, progressive airway disease, cardiac disease, and chronic diarrhea. In the attenuated type, there's no central nervous system involvement. Enzyme replacement therapy, when initiated early, can prevent irreversible damage for this condition. Early detection and initiation of treatment in MPS 2 is thought to be beneficial for neurological development. There are some thoughts that a small amount of enzyme crosses the blood-brain barrier, and so if infants are treated early, then they may fare better neurologically than later treated severe patients. Starting treatment early in life is also much better for the systemic health issues in this condition. Earlier treatment may lead to better growth and slower progression of the disease. Later this year, our department at Lurie Children's will be involved in a clinical trial for severe MPS 2, which has shown to have very good outcomes for the neurological disease in earlier phases of the study. So there's some excitement research going on. Niemann-Pick disease type A leads to enlarged liver and spleen, a cherry red spot in the retina, recurrent respiratory infections, and neurologic deterioration. Children with type A generally die by 3 to 4 years of age. In type B, there's a later onset with no neurologic involvement, but still an enlarged liver and spleen, thrombocytopenia, and pulmonary function deterioration. Treatment for type A includes physical and occupational therapies to maximize function and prevent contractures due to neurologic deterioration. A feeding tube to supply adequate nutrition and stem cell transplantation is under investigation. For type B, blood transfusions may be needed, as well as supplemental oxygen. Enzyme replacement therapy for Niemann-Pick is under investigation. In Pompe disease, the symptoms of the infantile form include hypotonia, generalized muscle weakness, cardiomegaly and hypertrophic cardiomyopathy, feeding difficulties, failure to thrive, respiratory distress, and hearing loss, with death generally within the first year of life. The late onset form of this condition involves proximal weakness and respiratory insufficiency without cardiac involvement. Treatment includes enzyme replacement therapy, physical therapy, and respiratory support. Severe combined immunodeficiency, or SCID, will also be added to the Illinois newborn screening panel. This condition is sometimes referred to as the bubble boy disease. This condition actually has several different types, all of which lead to an absence of T lymphocytes, a type of white blood cell that plays a significant role in immunity. In the absence of T cells, the immune system is severely compromised, which leads to recurrent infection. While not required by the Department of Public Health, they recommend screening also for critical congenital heart disease, about 15% of which have a genetic cause. Some examples include Down syndrome, Noonan syndrome, Turner syndrome, Holt-Oram, velocardiofacial syndrome, and many others. There are some limitations to newborn screening. It's important to understand that screening does not equal diagnosis. So additional testing is needed to evaluate a baby with what's called a positive newborn screen. It's important that a family is referred to a state-approved newborn screening center so that appropriate testing and counseling can be offered. Genetic counseling can be helpful for families in order to understand the inheritance of the condition, what it means to be a carrier, and in most cases carriers don't have symptoms, and what it means to be affected. They also need to understand what it means for other family members and or future children. Most of the conditions on the newborn screen are recessive, which we'll talk about. So if a couple has one affected child, they have a 25% chance in each pregnancy of having another affected child. It's helpful for families to learn about newborn screening prior to delivering their baby so that they better understand the process and the possible results. This hopefully makes the testing process less intimidating and helps reduce anxiety. I'd be happy to take a few questions from the audience before we move on to discuss family health history.
And if you'd like to go ahead and use the chat box to ask those questions, go ahead and do that now, and we'll let Michelle answer those questions. Just go ahead and chat them in on the lower right-hand side of your screen.
Some questions that we had for you, if nobody else has questions, is we were wondering what challenges you've encountered regarding newborn screening to this point. Wondering if you're familiar with the protocol for referring newborns to a state-approved center, and what, if any, additional education about newborn screening would be helpful to you. So if you have any answers to those questions, that would be great. So there was a question from a participant, exactly how does the stem cell transplant help? So stem cell transplant, essentially you're infusing cells that have the ability to differentiate in many different ways, and essentially you're bringing new cells into the body that are functioning correctly to help compensate for the cells that are not functioning correctly. Hopefully that answers that question. Someone else asked, do we know when the congenital heart defects, the screening for this will become law? I don't know the answer to that.
It seems that other states are looking into it, and some other states have passed it, so we don't know at this point for Illinois, but according to the Illinois Department of Public Health, close to half of hospitals do screen for critical congenital heart disease.
Someone else mentioned that the problem in their area is that the local health department performs the newborn screening, but they don't have a specific agreement with genetic counselors at the hospital in their area. And so because of that, they spend grant money, they have to get grant money for a genetics program to get transportation for the patients to Chicago to see a genetic counselor. That certainly is a significant barrier, and I'm not sure I have a solution for that. And I would think that if there are genetic counselors in the area, they should be able to handle some of these issues, even if they're not, you know, a state-approved center. I would encourage you to contact the state and make sure they're aware of the situation and see if they have other suggestions. Emily, I don't know if you have anything to add to that.
I don't, but I do see a question here about with bordering states in Iowa, Indiana, and Missouri, are there great differences in what they screen for? And there's a comment about, you know, how much mobility there is these days. And one of the great resources we'll have later on in the slide is the Baby's First Test site online, which you can go in and check which state is screening for what disorders, and so that you can have an idea of any differences or overlap between states.
There is a question, someone commented on, you know, there's so many of these conditions being added, typically result in early death if not treated. And the question was, does early detection and treatment of the disease from newborn screening reverse the prognosis or likely early death? In many cases it does, which is why these conditions were added or are going to be added to the panel, because if they're identified early and treatment is started, you're preventing a lot of the significant complications of the condition.
We do have a comment here from Claudia Nash at Illinois Department of Public Health, and she says that legislation is pending this spring to require hospitals to screen for critical heart disease. And so when that happens, the Illinois Department of Public Health will have to amend the newborn screening administrative rules before this can go into effect. So this can take a little bit of time. Claudia Nash says this might take up to a year, but that is really great news that there is some legislation pending, and hopefully that will be added in the future because it is saving life. Thank you, Claudia, for letting us know about that.
Someone else asked if there's a list of genetic counselors for referral in Central Illinois. On the Center for Jewish Genetics website, we do have some information about local genetic counselors, and on the National Society of Genetic Counselors website, there is a way to locate genetic counselors in your area as well.
So I think we might move on to the, even though we're getting some great questions coming in here and comments, I think we're going to move on to our next discussion, which is about the interaction between newborn screening and family health history. And Michelle will be presenting on that.
So family health history is an important tool to uncover health risks that a family may not be aware of. Many of the conditions on the newborn screening panel may present as unexpected childhood death in the family history if the childhood was not diagnosed and therefore not treated. Something else to keep in mind is that, as I said, newborn screening is just a screening test, so you need to also, evaluate a baby based on the family health history as well. Many common diseases have a genetic component such as diabetes, heart defects, cancers, and inheritance of these conditions is considered multifactorial, which means that they're caused by a combination of factors, including one or more genes and environmental or lifestyle factors. Healthcare providers can talk to their patients about their family health history and discuss options for risk reduction, which may include lifestyle changes such as diet and exercise, medications, and/or genetic testing. It's important to encourage families to gather their own family health history because ultimately it's up to them to obtain the information. There are several online tools to help families compile this information, such as the Surgeon General's Family Health Portrait tool. Other conditions are caused solely by a genetic mutation and are considered Mendelian disorders. So it's equally important for families to know if these types of conditions run in families because it can influence their own health risks as well as that of their children. I'll briefly discuss several different types of inheritance. For conditions inherited in an autosomal recessive manner, a carrier is someone who has one normal copy of the gene and one copy with a mutation. Carriers for most recessive conditions do not have symptoms, and there may be no family history of these conditions. Two carrier parents, so two healthy, unaffected individuals who each have one copy of a mutation, have a 1 in 4 chance, or 25% chance, of having an affected child in each pregnancy. Some examples of conditions inherited this way include PKU, sickle cell anemia, Krabbe, Pompe, MPS I, which we've talked about, Gaucher disease as well, a condition called beta thalassemia, and Tay-Sachs disease, and that's just a sampling. Generally, for conditions that are dominantly inherited, an individual with a mutation has symptoms of the condition. There are a few exceptions to this due to something called reduced penetrance, but for the most part, when an individual has a mutation for a dominant condition, they themselves have symptoms. If one parent is affected, there's a 50% chance that each child will be affected, regardless of the gender of the child. Examples of disorders inherited in this way include torsion dystonia, neurofibromatosis, and Huntington's disease. X-linked disorders are conditions that are caused by mutations on the X chromosome. Mostly males are affected, but females can be affected as well. Examples include Fabry disease, MPS II or Hunter syndrome, Fragile X syndrome, which is a common cause of intellectual disability in males, and Duchenne muscular dystrophy. Unaffected female carriers can have affected sons in an X-linked condition, and affected males do not pass on the condition, but their female offspring can be carriers. If a genetic disorder is identified in a family, regardless of the type of inheritance, a healthcare provider or genetic counselor can discuss who in the family is at risk and offer appropriate genetic testing. Knowing the family history can also help diagnose a newborn baby who's exhibiting symptoms of an unknown condition. And I'd be happy to take any questions about family health history, and we might have a few minutes to go back to some of the previous questions as well. Thank you.
So if you have any questions about family health history, just chat them in, as Kathy just put up in your comment box.
While you're thinking about your family health history questions, there were a couple of other questions typed in earlier. Somebody asked if when a screen comes back positive for a condition, is the infant rescreened and are other tests done for confirmation or both? It's both. Often the newborn screen is repeated depending on the condition, and then if it's still positive, then they're referred to a newborn screening center, a genetic center, for further additional testing. For all of these conditions, as I said, the newborn screen is not diagnostic. There's additional testing that needs to be done to actually make a diagnosis of the condition. Somebody asked if Medicaid or other public insurance pays for treatment such as enzyme replacement. And I know that it certainly varies. I don't know if you...
This is Marie Vonish. Hi. I have regular insurance, Blue Cross Blue Shield, and they do provide for it, and other insurance companies do also.
And unfortunately, I don't know the answer to that about Medicaid or other types of public insurance.
So I think we might be able to get that information and then talk about it later if we find that. If anyone else does know in the audience, it would be great if you could chat the answer in and we could share that with everybody participating.
And then someone mentioned, I think this went out to everyone, there's someone developing an iPhone app that will store family health history, which I think is great. As I said, there's a lot of online tools that exist, but I think, a mobile application would be even better, with the way technology is going these days. And the important thing is to get the information all in one place, and so I think something like this, certainly could be helpful. In terms of advice, I think it's, obviously making it easy to use, including as many generations of family members as possible. I think that's the limitation of the Surgeon General family health portrait, is that it doesn't, the family history doesn't go out very far, so it's not getting you as much information as you might want to include.
We had another question about how many disorders are performed in the newborn screening test, and I think Michelle talked about Illinois' number.
In Illinois, we currently screen for 29 core conditions and an additional 10 secondary conditions, and this doesn't include the new conditions that will be added.
And then for other states, you can check out the Baby's First Test website that it has a map that you can click on the different states that you're wanting to know about, and you can find out how many disorders they screen for and which ones.
Okay, so I guess one question someone was asking in regard to the these family health history programs, how far out are we talking about going? And certainly, your more immediate family members are going to be most useful, but even looking at, extending out to aunts and uncles, some of the programs, you're not able to do that. So just as complete as possible, within reason, I would say. And I think the last question we'll take, somebody asked, if a husband and wife are first cousins, are there things, genetic problems that we need to think about, even if the child has no symptoms? We certainly know that individuals a couple who are related by blood are at increased risk of having a child with a recessive condition. And the reason for that is two people who are related are more likely to have a mutation for the same condition because it's come from the same side of the family. So, if the child has no symptoms of anything, there's not necessarily a concern, but if symptoms do arise, that's certainly something to keep in mind. Is there some recessive disorder that could explain this because the family is related, because the parents are related?
Thank you, Michelle, and thanks to everyone who put in their questions. And now we're going to turn it over to our other presenter, Marie.
Hello, my name's Marie Vanish, and I have Fabry disease, and I have two sisters that also have it. I have 3 sons, and out of those, 2 of them have, and 3 grandchildren, and 1 granddaughter will most likely has it, but just doesn't know on symptom-wise. The other 2 grandchildren are from my son, and so it did not get passed to them. They are both male. I went to the gynecologist in December of '02, and they take a urine specimen just as a routine, and the doctor came back and said there's protein in your urine. I asked what I should do, and he said drink lots of water. Well, I started thinking about it. My father is one of 6 boys, and 5 of them had already passed away. And it was kidney disease on 2 of them. The other, they weren't sure because it was so many years ago. So I started thinking that didn't sound like a good idea. So I went to my doctor, and my doctor took a 24-hour urine test, which of course has blood tests connected with it. Everything came back perfect except there was some protein in my urine. So he put me on a pill for kidney medicine, and I took it for about 4 months, and I called back, and they had me come in, and I did another 24-hour urine with the blood, And they said, the nurse said, oh, it's much better. And so I was really happy, but I said, what was it, what should it be, and what is it now? So it was still up there. And I thought to myself, well, I'm 47 at this point. I have a heart condition, which we weren't sure exactly what it was. We were thinking AFib. And then now I'm on medicine for it, and now I'm on a kidney pill. So there's something wrong here. So I asked if I can go to a specialist. I picked out the specialist. He didn't say who to go to, so good thing I went to the right one. I went to the specialist, and she did the same 24-hour urine test with the blood connected to it, came back with the same results, just protein in my urine. So I asked her what we're going to do, and she said, well, since your family history, meaning my father at this point, just my father and his brothers, all dying except for one, 2 of them definitely from kidney disease, the other they didn't know what from, cold, the water in those days, they didn't know. So she said, I have to have a kidney biopsy. And I thought, ooh, that's a little dramatic. So I said, could I just drink lots of water and come back in 6 months? And she said no, because of family history. I had to do it within the next couple months. So I said, fine, let's just go ahead and do it and get it done with. So I had it done, and she came into my room and said, I have Fabry disease. So we had a family meeting, my sisters, my husband, you know, we were all there having this family meeting that this is what I have, so most likely they have it. They weren't saying much about what it was in the hospital. At that time, computers were just getting a little more where you get online. Of course, I didn't have one with me, so nobody would let me use theirs in the hospital. They didn't want me to know because they didn't say good things at that point because there was no treatment. So as luck would have it, the gentleman next to me, his wife was in the hospital, so I'm laying in a hospital bed, she's laying in the other one, and he happened over here. He went home, he came back the next day and said, I'm very sorry, I didn't mean to overhear your meeting, but it's kind of hard not to. He said, but you'll never guess what. I was watching Channel 9 News, which is a local station, and there was a gentleman on there from Canada, a young gentleman in his 20s, that comes to Children's Memorial every 2 weeks for enzyme replacement, because the doctors had no idea where to send me, who I should call, or what I should do. So when the doctors came in that day, I said, guess what? I'm going to call Children's Memorial and figure this out. So I did. I got on the phone, I called Children's Memorial, and that's where it started. So they had me come in and they tested me. And the different symptoms are you're sweating, tolerance to heat and cold, skin problems, eye issues. And when I say eye issues, there's whorls in your eyes that has to be looked by that certain lamp through the eye doctor. High fevers are a big problem, stomach issues, definitely a problem, hearing loss, kidney problems, and heart, which is AFib. I have the 3 sons, so 2 of them are affected by it. One does not sweat whatsoever. Both of them have the heat and the cold intolerance. One has the skin issue. One, and also myself, have the eye issues. High fevers, we all do. Stomach, we all do. Hearing loss, my son was 20 years old. He was away at college. This was before we even knew anything about Fabry disease, or I would discover I had it, that he lost hearing in one ear. And so he is totally deaf in one ear. I went to 3 specialists. They all thought it was sudden hearing loss because they had no idea we had Fabry disease, which it was not. Kidney problems I have, and then the heart, my sister and I also have AFib, and my oldest son. It affects your brain, your heart, and your kidneys, and it could affect 1 or all 3 or whatever. Mine is all 3, and like I said, my one son is kidney, the other son is the heart, and my sister's the heart. So that is how we figured it all out, and I do have AFib and also a pacemaker, and my sister has a pacemaker. For treatment in October of 03, they just came out with treatment in in April of 03. So by the time we figured this out, because it was June of 03 when I had the kidney biopsy, by the time we figured it out, I was able to get into treatment along with my son and my sister in October of 03, because they tested my family and saw who had it. We were going to Children's Memorial Hospital every 2 weeks for 8-hour sessions, and then those went down to like 5-hour sessions, and eventually they would let you have them either at a clinic or at home. So we all now, my one sister, myself, my 2 sons, all have treatment, and 1 niece. I did forget to mention, I'm sorry, I have 2 nieces and 1 is affected. We all have them at home now. It is so much easier and nicer. It takes about 2.5 hours, 15 minutes before, 15 minutes after, and 2 hours for the infusion, for the replacement. And it's just great that we could do that. It's just a better setting and more peaceful and more just not disruptive to our life. We believe my grandmother had it and she was never diagnosed. My father was never diagnosed along with his brothers. So that's what we believe, how we found it, and we tracked it back. And being a male, my father passed away from the disease at an early age of 38. Some of his brothers were in their 20s, and the other was a little older. And he ended up having a kidney transplant at the time, which it just became available. And so this is my family history, the last 2 charts. And how it affects our family in terms of employment and social support. Employment has not been an issue for me so far. I've been with the same company for 23 years. My son was let go from a job after he had promotion after promotion and raise after raise after raise, and he asked the owner why, and the owner could not give him a reason. So we really believe it was because he had just got on the insurance, and he did not sign up when everybody else signed up, so they were able to spot that he was causing the company a lot of money. But I have not had an issue. My work's very supportive about it. Socially, it's been fine. My friends and family are very supportive. You know, I feel that the more people that know about this, the better, just so they could be screened. Not everybody's going to have this. It's a rare disease. But if once it's in a family, it's in a family. And newborn screening, I feel, would be really helpful. There's 2 issues, though. One, there's false negatives for females, because I was diagnosed through the biopsy. Then they took the blood test for the screening for February along with my sons, and my sons came back that they were affected. I came back that I was not. But, of course, we knew I had it because I gave it to them. So then when they do further DNA testing, they figured out, of course, I have it, which we knew. So that was one issue for me, but I am really supportive of it because males don't live as long because they only have one X and they're more affected. And also life insurance. If you were to be labeled right away at birth, would you be able to get life insurance? That's going to be a big issue because right now life insurance is an issue with us. You know, if we go to get life insurance, they don't want to insure us. So we get it through work, you know, the minimum. And so that would be my issues. But other than that, I really believe newborn screening is the way to go.
Thank you, Marie. That was an amazing presentation, and thank you for sharing, you know, your family's health history with us. And we do have about 15 minutes if people would like to ask us some more questions specifically to Marie and how it's been for her and her family and her journey to diagnosis, or we also could answer some more questions about family health history and newborn screening.
And this is Marie Vanish again, and I just want to add one thing. Every time I go for a test or the hospital for anything, even if it's not related, I explain to every nurse and doctor because they have not heard of this disease. So I kind of educate as much as possible, and they're very open to it. Like whenever I go for echoes for my heart, the tech kind of wants to know why, and so I explain it and I educate them. Also, I've talked to different pediatricians in my area, and my children's pediatrician never caught it, and he feels really bad, but you can't blame him. It's something you need to be tested for. He actually is on the board at the 2 hospitals that are in Joliet, Illinois, and he brought it to all the pediatricians. So they have literature on it, and they know what to look for. Because you really should catch it in children, but it's really hard to. Because we all had these issues, and everybody had a little bit different. You know, we all had stomach aches, but this one had this one had that, and we blew everything off as time went on. But then when you know now you have Fabry disease and these are the issues, you go back and go, oh, that's why this happened. That's why every time I have surgery I have high fevers. So it is really good to catch in the early stages, but it is very difficult too.
So Marie, can I ask you a question as we are waiting for more questions to come in? Do you feel like if you would have known earlier, that would have saved you a lot of money and time trying to find out this or through your children as well?
Not money as much, time. In some senses, I'm very happy that we found out later because I would have raised them differently. But then again, in some circumstances, it would have been better because I would have known what to look for, like the one that doesn't sweat. It took me 3 pediatricians to get them to do a sweat test. They kept saying, why? We told you he doesn't sweat a lot. I said, I want to know how much he doesn't sweat. So 3 pediatricians I had to go through. And finally they took the sweat test, and the nurse that did it was like, oh my, I've never seen that happen before. They put the medicine on, and it looks like a wristband watch. It didn't move. She said, I'm taking the test over in the exact same spot. So they took the test over, and it still didn't move. He did not sweat at all. So now when we look back and we remember that one time at the zoo, the one time at a park where he was really overheated, he probably should have gone to the hospital for, you know, dehydration and a heat stroke, but not knowing it. So there would be a lot of places that it would have been nice to know.
Yeah, definitely.
Thank you.
Thank you so much for that.
Claudia Nash, if you're still on the call, somebody asked about something that IDPH produced called Genetic Services in the LHD and wondering how to get a current version. I don't know if you'd be able to comment on that. And then a couple of questions I'm not sure I fully understand what the question is. Someone asked if are you planning to implement a health history questionnaire with the screening test? Certainly, there are a lot of different family health history questionnaires available, both online. Most doctors' offices have their own version of a family health history questionnaire. As far as I know, it's not currently included as part of newborn screening, but the individual physicians generally do address that.
We do have a question about the MPS I disorder, about especially defining the course features.
So what course features means is it kind of means, like, it is hard to describe, but kind of very rough, kind of strong features, I would say. Not kind of delicate features that you would not expect to see in a baby. Thank you, Kathy, for posting that. As the phone number people can call to get a copy of that Genetic Services in the LHD, and they can send you a copy of that.
Okay, so we also have some resources for people to look up so that you can continue to educate yourselves, other staff, and other colleagues about genetic disorders and genetic health. And right at the top, we have the Illinois Department of Public Health Genetics Program. This is a great resource. And we also have Genetic Education for Illinois, which is a site that the Center for Jewish Genetics keeps up with the Illinois Department of Public Health, especially around DNA Day. And we also have the Baby's First Test, which I referenced. Here's a resource here for newborn screening for practitioners that has additional information. And we have the family health history from the Surgeon General here, and more information about Fabry disease, as that might be of interest to you. And we've also included our references so that if you want to go back to some of these sources, you feel free to do so.
And just wanted to point out, thank you to the participant who posted your own personal story. She said, my niece was diagnosed with VLCAD disease because of newborn screening, and she has been treated since birth, and she's very healthy at 4 years old. The newborn screening saved her life. It's great to hear stories like that, because that's certainly the point of the newborn screening program.
Somebody else also said that the Illinois Health Departments have a family health history questionnaire that is used as a screening tool with all pregnant women that come into the Women and Infant Children's offices and case management offices, I believe is what that says, CM. And so that would be something to look out for and remember that they have as a resource. Okay, so if we don't have any other questions, we're going to go ahead and end the program. And as Kathy mentioned, you received the evaluations, and once you complete that, then you can send it back in to INET with the fax number is included at the top of the evaluations and the email, and then you'll receive your nursing contact hour.
Sorry, one last question that I want to respond to. Someone asked, can parents refuse to have the screening done? And they said they recently encountered this. Yes, parents can refuse it. There's a form I believe they need to sign that they're actively refusing the testing. They don't need, conversely, they don't need to consent for newborn screening. So if they don't know that it's being done, they don't have the ability to refuse it. But again, the IDPH can comment on this more specifically as well. But I believe that if parents feel strongly for religious purposes or anything else, they can decline the newborn screening.
All right. Thank you so much, Emily and Michelle and Marie. Excellent webinar today. Excellent information. And you guys have been a great audience as well with super questions. As Emily said, please return that evaluation to us. We will email you a copy of your Nurse Contact Hours certificate. Even if you're not requesting Nurse Contact Hours, please send that evaluation back to us. It's very helpful for us and for the Center for Jewish Genetics and future planning for programs. If anyone in your organization missed this webinar, they can watch an archived version of the webinar. It will be on our website starting tomorrow. Again, that's illinoisnetwork.org. And if you have any other questions, feel free to email us or give us a call. Emily, any other final comments?
No, just thank you so much for participating and being interested in genetic health.
Great. Thanks, everybody. Have a great day.